Hello, my name is Walter Sonny Zeke, and I'm a member of the Blood Transfusion Service at the Massachusetts General Hospital. And it's my pleasure today to speak with you about transfusion medicine issues for the clinician. I really want to start by congratulating the people who are here in attendance, because I recognize that you're listening to this presentation means that you've taken an investment in your own professional career and in the welfare of the patients that you serve. This is time away from your family or from other pursuits. And I just wanted to just acknowledge that I understand that you're doing that, and I want to congratulate you for it. I have no conflicts of interest to disclose to you, and I'm the editor of a international medical journal on transfusion medicine. And I recognize that often clinicians don't receive a lot of formal training in transfusion medicine. And so I hope during my presentation to give you an update on some of the facts, some of the evidence that we know from the literature. I want to start with the history and just show you this image. This handsome guy, and nice curly hair, is that of James Blundell, who's considered really the father of modern transfusion medicine. He was an obstetrician practicing in London in the early part of the 19th century. And he witnessed, of course, bleeding at childbirth, which was then and still remains a serious cause of mortality for women. And he set about to create the principles necessary to safely transfuse blood to them at the time of postpartum hemorrhage. One of the principles that he outlined was that one should use blood within the same species, because prior to that, there had been attempts to transfuse blood from animals into humans. And he put an end to that practice once and for all, thank heavens. His actual first case, which is shown here on the right, was in a cancer patient. It was a person who had a gastric cancer and was bleeding, and that was his first attempt to try transfusion, though he quickly moved to exploring its use in pregnant women. He was kind of an inventor type and focused a lot on different instrumentation. And one of the things that advanced the field then, and continues to advance it today, were better devices to accurately control the amount of blood transferred from the donor to the recipient. You can see in the drawing that in those days, the donor was right there at the bedside standing up, and we could tell when the donor had given enough blood because he would kind of pass out, and it was time for them to stop. This is the field today, a little more modern representation of the field. And I want to just point out that while on this talk, we'll be focusing just on the top of the slide, the clinical use of blood, there are quite a few other aspects to transfusion medicine in the United States, and time doesn't allow us to get into all those, but it's a field with very broad roots. I do want to highlight one other aspect other than clinical use in particular, and that's this issue of donor services. You may or may not be aware of the fact that we're undergoing a rather severe shortage of blood in the United States because of COVID. COVID has created tremendous restrictions on the gathering of donors, and so there's a very severe shortfall in blood availability in the United States, and many blood centers have actually less than a one-day supply of blood for hospitals. And this means that those of us who work in hospitals need to use blood as conservatively as possible so that it can be used most wisely. And that would be some of the lessons of today's presentation. Before we get into clinical use, I also wanted to show you this particular graphic, which is a kind of a well-established one now, that looks at the adverse effects of red blood cell transfusion, though it applies broadly to plasma and platelets as well. And the vertical lines on the graph, as you can see at the top, are powers of 10. And the point of the graphic is to understand that the transmission of viruses like HIV and hepatitis C and B, which for decades were the major concern of the field, and which to this day frequently are a concern among patients, are actually not the major risk of transfusion at all. The risk of HIV or hepatitis C is a less than 1 in a million shot We don't even know how far to the left of this graphic it should be placed. It's somewhere on the order, as you can see at the bottom, along with being struck by lightning. So it's a very, very rare event. In contrast, there are other adverse effects which remain more common. And the two to point out are in the red box here, namely TRALI and TACO. I don't like the term TACO, but it's an established term, which stands for transfusion-associated circulatory overload. We could just call it volume overload, would be simple enough. But TRALI and TACO remain among the more common adverse effects of transfusion. So I just want to distinguish them a little bit on this slide. TRALI, which most people now have heard about, is turning out to be increasingly a rare complication, which is a great thing. TRALI stands for transfusion-related acute lung injury and basically looks like sudden ARDS following a blood transfusion. It occurs within minutes to hours of the transfusion event and results from donor antibodies. So these are antibodies in the bag, donor antibodies, which are directed to HLA or neutrophil antigens. The reason the donor has them is because these are donor units supplied by multiparous females. Women who've had, multiple children frequently make HLA antibodies to the HLA type of the father. So if this multiparous woman serves as a blood donor, she may have these antibodies in her plasma. And the antibodies, once transferred to the patient, can react with pulmonary endothelium, fix complement, and basically poke holes in the pulmonary endothelium and flood the alveolus. The incidence of TRALI is very much on the decline because the organized blood systems that collect donor blood are increasingly excluding parous females from the donor supply. So when you request blood for a patient, increasingly you are unlikely to receive a unit of blood which has been donated by a woman who has children at home. In contrast, TACO, or circulatory overload, is quite common and is essentially underreported. It's felt to be on the order of 100 to 1,000 times more common than TRALI. So this is what you should think about when a patient develops sudden pulmonary insufficiency following transfusion. The risk factors are listed for you there and are the kinds of things that occur commonly among transfused patients. And the frequency of this is actually not exactly known, but is felt to occur as perhaps as common as 5% of intensive care unit patients. So this is a common complication to be on the lookout for. Okay, let's move away from complications and into transfusion. So I've got my first little vignette would focus on red cells. So here we have a 65-year-old man with myelodysplastic syndrome, and he has decreased exercise tolerance. He's got a hemoglobin of 8, low risk genetics, there's a history of hypertension, a little bit of renal insufficiency, and on exam has a full JVP and some pedal edema. So there may be some element of heart failure in this man. And the question before us would be, would a red cell transfusion help him? Would it make him better, make this outpatient have a higher quality of life? That's the question. And it gets to the issue of why would you give someone a red cell transfusion? When you look at the physiology of oxygen delivery, it's of course extremely clear that oxygen delivery to tissues does not depend exclusively on the hemoglobin. And this graphic kind of nicely shows it. It plots hemoglobin concentration on the y-axis, oxygen delivery on the x-axis, and then the diagonal lines are different levels of cardiac index. And it's obvious that if you're sitting at that big blue dot with a below normal oxygen delivery, you're a little left of normal there, you can move to the right in one of two ways. You can either keep your hemoglobin there at 6, where my arrow is, keeping your hemoglobin at 6, and basically increasing your cardiac output to get your index up to 7. However, if you have a fixed cardiac index, if you're older or have some heart disease, and cannot improve your cardiac index above 5, the only way to get to this 600 mLs of oxygen per minute per meter squared, the only way to get there is to raise your hemoglobin. The point is that in making a decision about giving someone a red cell transfusion, it's physiologically relevant and important to consider both their hemoglobin concentration, but also their cardiac performance, right? So it's a two-dimensional problem at the least, that you should include both hemoglobin and cardiac output in your thought process. The interaction of these two variables was never better shown than by Jeff Carson a long time ago in a really interesting retrospective study that looked at the adjusted odds ratio of major surgical mortality or major morbidity as a function of hemoglobin. So what you see here on the x-axis is the preoperative hemoglobin of patients. And on the y-axis is the adjusted odds ratio of something bad happening. And what the data shows you is so interesting because it's so dramatically different. If you follow the dotted line, someone who does not have cardiovascular disease, it really hardly matters what your preoperative hemoglobin is. And that's because your heart is able to compensate over a range of hemoglobins that we normally encounter in the Western world. On the other hand, looking at the solid line, you can see that if you have fixed cardiovascular disease, now you become very susceptible to the effects of anemia because you're unable to compensate for low preoperative hemoglobins. So the purpose of this study was really to show the mutual dependence of cardiac performance and hemoglobin on outcomes of patients. This idea was taken further in trying to understand what the trigger should be for transfusing red cells. And a whole series of trigger trials were done. The first big one was called the TRICK trial, and it dates as early as 1999, so quite a long time ago now. And it was done by Paul Hébert in Canada, and was a randomized controlled trial that randomized patients who were in intensive care unit. He excluded cardiac ICU because everyone was afraid to fiddle with the hemoglobin of people with heart disease, but we'll come back to that in a moment. So he took patients who were not in the CCU, so they were non-cardiac ICUs, and randomized them to a restrictive strategy in which they were transfused for a hemoglobin of 7, so a crit of 21, and kept in the range of 7 to 9. I can tell you at the time that was considered like crazy. Why would you let someone's hemoglobin drop that low? And the other arm was the liberal transfusion strategy, where the trigger was 10, and patients were kept in a range of 10 to 12 hemoglobin, which was really the standard practice of that era. It made the New England Journal because the results, which are shown here, were so surprising. What Hébert found was that the liberal strategy of keeping patients well supplied with blood was definitely not better than the restrictive strategy. In fact, the p-value wasn't even close. So he could find no evidence that using a conservative approach, the restrictive strategy, was harmful in any way to the survival of patients in critical care. People didn't really believe this when it first came out because it seemed so odd, although nowadays it's almost standard for us to use 7 as the trigger for transfusion based on Hébert's original study. But people didn't kind of believe it at the time, so the studies were repeated. And this graphic shows you the extent to which they were repeated. So all of these studies on this slide, and is decades of work, represent trigger trials, and they're all structured the same way. If you look at the column labeled trigger, one group gets randomized to a low hemoglobin trigger and the other group gets randomized to a high trigger. If you look at the setting, you can see they range everything from newborn babies to elderly people having hip surgery, and they involve thousands of patients on the far right-hand column. And the bottom line in these studies is that there was never in any of the studies an advantage to a more liberal approach to transfusion. I want to just highlight the bottom two because they're so recent. One was the reality trial at the very bottom there by Ducrocq. And this really caught a lot of attention because this was for the first time where they kind of took the bold step to do a trigger trial in patients who are having an acute MI. As I mentioned at the beginning, talking about the TRIC trial, Paul Hebert was worried about going into the CCU because no one thought it wise to restrict transfusions in patients having an acute MI. But that's exactly what was done in the Ducrocq study, and again, showed no advantage to a liberal strategy. The TAY study, next to the bottom line, is relevant to you all, to this audience, because it was done in stem cell transplant patients. So I want to cover that one in a little more detail. Here's the summary. No trial showed benefit. And here's just a one slide on the TAY study. This was a Canadian RCT of red cell transfusions after stem cell transplantation. 300 patients, kind of a mixture of both allos and autos. And the patients were randomized to either 7 or 9, your typical trigger approach. And the primary outcome here was quality of life, using a kind of a structured scoring approach for quality of life. And you can see in the graphic on the right that basically everything crosses the 0 line. So there's no signal at all of the quality of life being favored by a liberal transfusion strategy. If anything, the point estimates are slightly to the right, slightly in the blue zone there, favoring a restrictive strategy, but the confidence intervals cross 0. So I think it's better to say there's just nothing there. And it's true regardless of which subgroup you look at, including older people versus younger people, like over 60 versus less than 60. So we haven't had a trigger trial kind of in stem cell transplant patients until this most recent one that just came out. And so I think this one is especially relevant for your patient population. Turning back to the patient, remember our patient was a guy with MDS, and we were trying to decide, should we give him blood for his hemoglobin of 8? And the problem with all those trigger trials that I showed you is that they were all inpatients. And we've really had a dearth, almost an absence of any studies focused on outpatients, which is really unfortunate because there are so many outpatients. And I wanted to bring this one to your attention because it came out in the last couple of years and is really the best study thus far looking at the effect of transfusion on outpatients and their quality of life. And so this looked at the relief of fatigue using a standardized fatigue score in 204 outpatients. They had myelodysplastic syndromes or hematologic malignancies. You can see the age bracket. The hemoglobins were what you'd expect in the 7 to 8 range. And they did serial fatigue scores before the transfusion, and then at 3 specified intervals, day 3, 7, and 28 after the transfusion. And in the upper right-hand corner, you can see in the graphic, just look at the solid lines. The dotted lines are just modeling. The solid lines are the actual data. You get a sense, there's maybe a little bump at the day 3 mark, but pretty quickly everything turns rather horizontal. And so they really do not demonstrate any sustained improvement in fatigue by a red blood cell transfusion for this category of patients who are in that hemoglobin range. In the lower right-hand corner, you get a sense of the sustained response, basically the proportion of people with a sustained response. And you can see that some patients, like 30, if you look at the lower right-hand corner, 31% had a kind of improvement and an equal number got worse. It was basically a balanced response. So as a cohort, you don't get much here. There may be individual patients who get an improvement with transfusion, but basically this study goes down as a negative study for demonstrating any significant outpatient transfusion effect for hemoglobins in that range. Okay, let's leave red cells behind a moment change gears a bit. So here's another case you might be involved with, one like this. This is a 48-year-old man. He's got fever, weight loss, B symptoms. He's clearly sick, and he gets a workup, and his CT scan shows he has a mass in the liver, and he needs a biopsy. And so you're asked as a hematologist oncologist to advise on his pre-procedure coagulation and what should be done so that he can have a safe biopsy. His physical exam is essentially negative. There's no splenomegaly. His CT shows a substantial lesion in the liver, and his labs show clear evidence of impaired liver function with elevated alk phos, ALT, and LDH. May have a lymphoma in there or some other disease, maybe hepatocellular carcinoma. And his coags show an INR of 2.4. PTT is pretty much normal. Fibrinogen's okay. H&H are okay. Platelets are okay. So if you kind of look at what I've set up here, it kind of focuses a bit on the INR, which I put in bright red so that you'd keep your eye on that number, 2.4. This is a very, very common question, what to do in terms of preparing someone for an invasive procedure with an elevated INR. That's the topic. So in thinking about this topic, I wanted to share this graph with you. What you see here on the y-axis is the percentage of clotting factors in the blood, right? With 100% being totally normal, and then decreasing levels of clotting factors based on, whatever disease you have. And on the x-axis is the INR, or prothrombin time value. The point of the graph is to emphasize that, the zone of normal hemostasis, where you'll clot perfectly fine, extends beyond the normal range of INR. So let that sink in a bit. So, look at the x-axis. If your INR is 1.5, 1.6, 1.7, your test isn't normal. It's outside the normal range. There's no doubt about that. But that does not mean you have a coagulopathy any more than if someone has a platelet count of 130,000, well, their platelet count is outside the normal range, but it doesn't mean they have a clinically important deficit of platelets. If your creatinine is 1.7, your creatinine is outside the normal range, but it doesn't mean that you have a clinically significant impairment of your renal function. So it's the same with INR. Though I think you'll see this mistake often made, that people will say, well, his INR is 1.8. He has a coagulopathy, and we have to correct it. Well, I would be cautious about endorsing that kind of thinking because it's not consistent, actually, with the physiology. It just turns out the INR test is very sensitive, and it will become abnormal before the patient becomes coagulopathic. So to chase this point a little further, here is an incredible study, and you rarely get the pleasure of showing something from 1981. Look at that, huh? Like, this is a long time ago and remains relevant. 200 patients undergoing a liver biopsy, just like our test case. Everybody's got abnormal coags. Nobody gets any treatment. And what did they do? They inserted a laparoscope. They biopsied the liver, and then they just watched the liver bleed. They left a laparoscopic device in the belly and just kept their eye on the surface of the liver where they had poked the patient and watched the blood come off the surface of the liver and counted the number of minutes it took for the liver to stop bleeding. What a simple, clever idea. And then, of course, what they said is, well, let's see if we can correlate the liver bleeding time with the preoperative tests. And there's no correlation at all. So on the y-axis here is your liver bleeding time. So this is blood coming off the liver. On average, it was 4.5 minutes before it stopped. And on the x-axis is the prothrombin time, essentially. And the details of the numbers are not as important as the quick observation that there's nothing here. It's a scattergram. If you try to do this, if you do the same thing with platelet count, it's also a scattergram. So there is not, and there's never been, any evidence that laboratory tests like the INR provide a tight association with hemorrhagic outcomes at the time of any invasive procedure, including liver biopsy. If you'd like to see some more recent data, this gets reproven over and over and over again. I just brought this one to you because there's a nice large number here. This is from 2017. 852 invasive procedures in a whole bunch of patients with cirrhosis. And you can see all kinds of procedures there. Paracentesis on the left to TIPS on the right. So some very big league deals. And what they broke the patients into some quadrants here. The upper rows are low INRs and the lower rows are higher INRs. The left-hand column are high platelets. The right-hand column are low platelets. And so, of course, the lower right-hand box are people with a low platelet count and also an elevated INR above normal, and the number of bleeds among those 41 procedures was 0. There's no signal here, and you can look at any of the procedures and you'll get kind of a similar flavor to there being no signal. So be cautious about trying to fix an INR to do this procedure with the thinking that you'll change outcomes. Now, another reason to be cautious is shown on this slide, which you've already seen, but now I've added some blue lines on this thing, these blue vertical arrows that you can see. And these blue arrows, where the pointer is, this increase in the percent factors is kind of what happens when you give FFP. You're infusing clotting factors. And what I want you to see is the difference in impact that has on the INR. So if we go over here on the right and you infuse factors into somebody with an INR of 3, you actually will get a rather substantial change in the INR. It will drop. But when you're over on this part of the curve, because it's not a linear curve, and you fuse the same amount of factors, believe it or not, these two blue arrows are the same height, you'll get like no change in your INR. It's not because the amount of factors are different, it's just the way the INR curve is designed. And so the point is that when you're transfusing people with plasma down in these physiologically normal ranges, you're not really going to get any effect anyway. And I can prove that to you with real clinical information from this paper. So here's a really simple paper from Holland and Brooks. I know these guys. It was published quite a few years ago now. They're in Oklahoma. They took a whole bunch of people and they gave them a bunch of plasma. And they had some patients who had relatively low INRs who did not get transfused. And then they did follow-up INRs, which is a very simple thing to do. And here's the point. So what you're seeing here is the pre-transfusion INR on the x-axis. And this is the decrease in INR. So it's the impact of the transfusion, the effect of the transfusion on the INR. Now, if your pre-transfusion INR is huge, it's way out here with an INR 8, INR 10. These people have really high INRs. You can only really get there from vitamin K deficiency or Coumadin. But if you have a patient out there and you give them 2 units of FFP, you will get a change in the INR, right? You look at these changes are dropping by 3 points with just 2 units of FFP. What's more important, though, I think in the graphic is look at all the transfusions. The clinical activity is happening very frequently in people with INRs below 2. All those people we were just talking about with these INRs of set 1.7 who don't really need the plasma, and look at the impact of the plasma on their INR. It's 0.0. Okay, this is all unuseful activity. There's nothing going on here. So there's 2 reasons not to be transfusing. One is that they don't have a coagulopathy in the first place. And the second reason is that you're not going to do anything if you're trying to change INRs. So here's my takeaway. Stop treating the INR. Mild to moderate elevations of the INR do not represent a clinical coagulation disorder. The INR test is useful once it gets way out there. So I'm not saying abandon the INR. I'm just trying to say don't overreact to it. Also, the clinical data would indicate there's really no value to pre-procedure FFP in nearly all cases, because as you know from your own experience, nearly all people who are getting a procedure do not have an INR above 6. There's tons of people with some moderate liver disease who are getting procedures at INRs of 1.8, 1.9, 2.1, but they're not people with extreme elevations. And, and then the third point, which I'll come to at the end a little bit, is that you get much more impact for local bleeding in procedures if you use local hemostatic measures as opposed to trying to fix it through the antecubital vein. All right, now to the meat of the matter, since you're hematologist oncologist, our third case. So here's a 58-year-old mother of two, and she has new AML, and she's undergoing induction chemotherapy. She's afebrile, she's got some petechiae, there's no splenomegaly. Here's the labs, typical AML labs, platelet counts 19,000. You decide to administer a platelet transfusion because she has dropped to 19,000, and she has chills, fever, and nausea. And so we're going to kind of look at this case and ask the question a little bit, did she need this transfusion in the first place? And also, why did she have these chills, temperature, and fever? What happened here? So let's address that question first. Why did she have that reaction? And the answer has to do in the history, as it so often does. So this is a mother of two, right? She has two kids. So if your patient is a woman and she's got kids at home, and she's under your care, you have to always be prepared for the fact that she may already be HLA sensitized from those prior pregnancies, even if they were decades ago. So women with prior pregnancies become HLA allosensitized. They hold on to their HLA antibodies, and those HLA antibodies, if present, will then react with the HLA antigens on the platelets, and they'll have these febrile reactions. They'll get no bump, they'll get sick, and you won't have accomplished anything because they're not going to get any response to the transfusion. How do you know if this is going on? Well, if you have access to this assay, take advantage of it. We have it here at MGH. We use it all the time. It's called the single antigen bead assay. It looks for HLA antibodies. It uses a Luminex machine. It's very simple to understand, totally cool test. What you get in the lab are a series of beads of different fluorescent colors. And each bead is individually coated with a different HLA molecule. You add these beads to the patient's serum. And if she has HLA antibodies, her antibodies are going to stick to whichever bead has the corresponding antigen. You can then tell if her antibodies have stuck by adding in another fluorescent reagent, which is an anti-antibody. So this fluorescent reagent will stick to whichever beads are coated by the patient. And so when you run that through the machine and react it with these across these two lasers, what you see is, first of all, you find out which beads had no antibody on them. They just passed right through the laser with no signal. And then you can also find which beads were brightly lit up because the patient was attacking the bead. And that shows up on this kind of a readout. So what you see, this is a typical HLA Luminex readout. And what you see on the y-axis in those colored bars are increasing amount of antibody attacking the bead. And on the x-axis are all these different beads with different HLA molecules on them. Each bead has a different HLA molecule. And so if you look here at the lower left at the beads that are under attack by the patient, you find out that these beads have the following antigens on them. So this patient doesn't like the HLA A63, A2, A24, et cetera antigens. This is very useful because now you can select platelet donors that lack those antigens, and the patient will then have no reaction and she'll actually get a bump. If you just keep grabbing random platelets, you're going to have a frustrating time with clinical reactions with no real increments in the platelet count, and you will actually broaden her allosensitization. So if you have access to HLA testing, by all means take advantage of it, HLA antibody testing, especially if the patient is a woman who's born children. You don't see this problem with nulliparous females or with men because they haven't been exposed. Okay, so that's why she reacted. How about the question, did she need the transfusion at all? You transfuse her because she sank below 20,000 down to 19,000. We would say, well, that really wasn't that useful for you to have done that because of data shown here in which a randomized trial was done to look at these two thresholds for transfusion. And it was demonstrated that there was really no difference in transfusing people at 20 versus 10. So the current standard is to use 10. Is there any value to prophylactic platelet transfusions? Well, this was addressed in the TOPS trial that was published in the New England Journal. It looked at kind of patients you take care of. They were enriched for autologous stem cell patients, but included those undergoing induction as well as allogeneic stem cells. And what they looked at was two strategies, either using prophylactic transfusion here on the right for people who sank less than 10 versus not giving prophylactic transfusions at all. And what was really interesting is that when you look at higher degrees of bleeding, that there was really no difference in the two groups. So they were really unable to demonstrate a significant effect from even using prophylactic platelet transfusions at all, even though they still remain the current standard of care. What about dose? This was a randomized trial on the dose of platelets, and it showed that whether you give 3 units, 6 units, or 12 units, it doesn't really matter. You get the same outcome when you look at the percentage of patients who have bleeding, they're, independent of the dose. So the dose you give actually doesn't really have much of an effect on outcome. This study, the dose study, is, I think, more significant for the following graphic. This is a really cool graphic, and I'd like you to absorb it. So what this is showing is the percentage of days with significant bleeding, WHO grade 2 or higher bleeding, as a function of the morning platelet counts. And this is done based on prospective observation of bleeding. So this is not a chart review. This is on 24,000 occasions, someone walked in the patient's room and did an objective way to measure their degree of bleeding. And what they found, counterintuitively, but worth absorbing, is this very horizontal line. It really doesn't matter. Once you're above 10,000, all the way up to 80,000, it really doesn't matter what your platelet count is. The percentage of days that you'll spend with visible bleeding is about the same, whether you're 20, 30, 40, 50, or 60,000. So be cautious if you're trying to change outcomes by making somebody go from 30 to 60, because it's not likely to. The data doesn't support that. To mention cryo, it's an important product. Just to say that it's a source of fibrinogen as well as of VWF. And so you can, the dosing that you can get is listed here on the slide. We typically use 10 units at our hospital for standard cryoprecipitate dosing, and is a great way to improve someone's fibrinogen level when it's low. Now, a word on drugs. I can't possibly cover all these drugs. I just wanted to mention one drug, which is the antifibrinolytic family, like Amicar or tranexamic acid. These drugs work by inhibiting the binding of the fibrinolytic proteins to clot. So the fibrinolytic proteins have lysine binding sites. Clot has lysine on it, and these drugs are lysine analogs. And so they block the binding of fibrinolytic proteins onto clot. And, there's now a very broad experience with them. And I've listed for you here some of the major studies involving tens of thousands of patients that show benefit to antifibrinolytics in specific clinical situations. I think hematologists, oncologists have been shy to use these, and I'd urge you to kind of learn more about this because you shouldn't be afraid to use these drugs. Lastly, closing, be cautious about taking local bleeding and trying to fix it with the antecubital vein. There are a lot of local measures that can be used, applied locally to stop bleeding. And so never hesitate to treat local bleeding with local measures. It's the most effective way to stop bleeding. Here are my take-home messages. I hope you'll review them, at your leisure. And I've, listed some references at the end that you can also see. So I do have some questions, and in the seconds that remain, I'd like to just run through them quickly with you. So it's easy, intermediate, and hard. Here's an easy one. A 70-year-old retired malpractice lawyer is under your care, and he says, gee, I need a transfusion. What should I be most worried about? Your choices are hepatitis, Zika virus, taco, trally, a human error causing him to get the wrong blood and having ABO hemolysis, iron overload, or always a good choice. I'll have my own attorney get back to you on this question. So the correct answer here is circulatory overload, TACO, right? It's by far the commonest adverse effective transfusion, outweighing trally by at least 100-fold. So that's the correct answer to this particular question. All right, let's try something a little bit more challenging. Here's a 40-year-old man with minimal prior transfusion who has cirrhosis due to alcohol. He's getting Levoflox for an infection. He has a platelet count of 21. He gets an adult dose of platelet transfusion, and 45 minutes later, his count is only 28. Didn't get a very good bump. His white count's 3,000, his grit's 21. And the question to you is, what's the most likely cause of his poor response to platelet transfusion? Is it A, insufficient TPO because he has liver disease, B, HLA sensitization, C, drug-associated thrombocytopenia, perhaps that Levoflox, D, splenomegaly, or E, acute alcoholic marrow suppression? So you have a chance here to kind of think a second, vote your conscience. And the answer is D, splenomegaly, right? TPO has nothing to do with his response to a transfusion. Men are not likely to be HLA sensitized, particularly with minimal prior history. Levoflox is not your most likely cause of drug-associated thrombocytopenia. More common drug would be something like vancomycin. Splenomegaly, by the way, will cause just this idea. You get a little bit of a response, but a very inadequate one because the transfused product all goes into the spleen. And marrow suppression, of course, is not going to affect transfused platelets. Finally, a difficult one, which is here really to show you how quickly simple matters can become challenging. Here's a 28-year-old woman undergoing intensive chemoradiation therapy for adult ALL with multiple agents, including L-asparaginase. Her platelet count is 12,000, but she has a clot. She has a swollen left leg and a popliteal vein clot. What should we do next? So we have thrombocytopenia, we have L-asparaginase, and we have a non-life-threatening popliteal vein clot, but nevertheless a clot in her leg. Should you transfuse her platelets to keep her above 50,000 and then give her full dose heparin? Should you give her aspirin? Should you measure her fibrinogen and then fix it if it's below 150? Should you measure AT3 and then give her heparin plus AT3 concentrates? Should you measure the AT3 and then give her DOACs? What about checking for HLA antibodies in her? What about putting in a filter? It's actually a very, very difficult question on what's the best thing to do for her because she has competing risks of both clotting and bleeding. There is no right single answer on this one, but I would share the following thoughts with you in trying to do the best thing by her. I would not pour in platelets in one arm and heparin in the other arm. That sounds like competing treatments and doesn't make a lot of sense. Treating with aspirin is not the standard treatment for a leg clot, but would perhaps take some edge off of her thrombophilia and is probably not that risky even at 12,000. I would definitely not replete fibrinogen at a level of 150 because 150 is fine. You shouldn't be treating patients who are just because they're below 150. Measuring antithrombin 3 levels and then trying to replace that does not make sense. AT3 has a very short half-life, and you'll yo-yo the patient. Their levels will go up and down, and their PTTs will be all over the map. I think you'll have a hard time with that. Measuring antithrombin 3 and then giving a DOAC, that really doesn't make sense completely because there's no reason to concern yourself with AT3 if you're going to use a DOAC. However, if you are going to use a DOAC, a low-dose DOAC like rivaroxaban at 10, you might be able to squeak by even at that platelet count. We really don't know. Measuring HLA antibodies really depends on our history of pregnancy. If there's no pregnancy history, don't worry about it. And putting in a filter is not something we would typically do in a person with ALL and a clot, but your mileage may vary in your hospital. So with that, I will conclude. Thank you for the extra time, and just show this slide that has some additional references that you might wish to take advantage of. Thank you very much for your attention, and I wish you the best of care as you treat patients with very serious illnesses of the bloodstream. Bye-bye now.